Welcome to the Loupe Podcast, where we are transforming education in plastic surgery since 2020. Hello, everyone, and welcome back to the Loupe Podcast. Today, we have a bonus episode for our in-service review series. This is a review of antibiotics and pharmacology. This was not taken straight from previous examination questions as per our previous episodes, but rather this is an overview of basically everything you need to know about antibiotics as a plastic surgeon. There are questions on this scattered throughout the in-service, and they mostly can be found in the soft tissue infection section as well as the general principles section. I have with me here today Dr. Erica Smearman, who is a resident with me at Emory University. She has an MD, PhD, and who better to review pharmacology with us? So Erica, tell us a little bit about yourself and maybe a quick overview of your PhD work.
Hey, so thanks so much for having me on this. I went to medical school here at Emory and then continued here for residency at Emory for my medical training. I did the MD PhD program. My PhD was focused on neuropsych, looking at how early adversity impacts our biology. Got into the clinical years of medicine and just love surgery. And I'm really excited to be a part of plastic surgery, hoping to do post-trauma reconstruction, post-cancer reconstruction, and just love all things biology. And I'm excited to be talking about this with all of you.
Erica put in the work for today's episode, as well as the content in a very, very helpful visual supplement to this episode that can be found on our YouTube channel. So make sure and check out this visual supplement, as it is extremely helpful with the diagrams to understand this pharmacology. Now, let's get started with the content.
The diagram that I have in here is something that I kind of combined from other lectures that I was looking at while I was preparing this information. And so we have links also to those YouTube videos. You'll see that some of them are structured similarly to what I have, but this has been tailored really for plastic surgery residents and practitioners in particular.
Okay. Erica, what are the considerations that we need to know about treating infections and using antibiotics?
Yeah, so there's a lot of things we have to keep in mind when we're going to choose an antibiotic to treat a patient's infection. First off, you have to think about the bacteria that you are trying to go against, what that bacteria is going to have in terms of resistance, where in the body this is located, and so what type of bacteria that's going to be. We also have to think about our host, our patient, and what other comorbidities they have. Do they have any sort of hepatic or renal dysfunction that we need to take into account given the antibiotic way that it's cleared and the toxicities that it may have? And then with that, the antibiotic, the pharmacokinetics of the antibiotic, any toxicities that antibiotic is going to have. So there's a lot that we have to keep in mind when we have a patient in front of us with an infection that we are worried about. So I'm going to touch on a number of those different things as we go through this.
Okay, now, can you start explaining antibiotic coverage and how these drugs work against bacteria? Let's start with gram-positive bacteria.
Our gram-positive bacteria are our bacteria that have a pretty prominent cell wall. That is in contrast to our gram-negative bacteria. So our gram-negative bacteria, they're going to have a cell wall, but that's going to have a lipid bilayer surrounding it as well. And so when we talk about antibiotics that are going to impact our gram-positive versus our gram-negative bacteria, we can keep this in mind because the antibiotics that really attack the cell wall, they're going to be particularly effective against our gram-positive bacteria because of that prominent cell wall, where the gram-negative ones, those antibiotics are going to have to get through this lipid bilayer to get to the cell wall. So keeping that in mind, we can start thinking about, okay, which antibiotics are going to be effective against our gram-positive organisms? These are organisms that we're going to find a lot on our soft tissue, infections of the skin in particular. And the base of this, looking at what's the first antibiotic that often people think about, these are going to be our penicillins. And our penicillins, they have a particular structure in them called their beta-lactam ring. And this ring is going to be consistent with the number of antibiotics that we have. What this antibiotic does is it goes in and it disrupts the formation of that cell wall. And so these bacteria, as they're being produced, aren't able to make that cell wall appropriately and aren't able to survive. Antibiotics have a certain mechanism by which they're trying to fight this bacteria. And the bacteria have developed ways to fight back. So there are bacteria now that have resistance against this in various ways. And so these penicillin antibiotics that work in this way are only effective in some scenarios now against certain bacteria that don't have these resistance. And so sometimes we have to kind of bump up our level of what we are providing in terms of the antibiotic so that we can fight bacteria that have developed this resistance. And there's different ways to do this. One kind of classic thing that we use next is going to be our vancomycin. And so vancomycin works from a different mechanism. It also disrupts the cell wall, but it prevents cell wall cross-linking in a different way than our penicillins do. And so vancomycin is a classic go-to when you want to cover gram-positive bacteria and you're worried about resistance, particularly our methicillin-resistant Staph aureus, because vancomycin at this time still can fight against this. Now, if we want to kind of move up the ladder again and have even more potent antibiotic, the classic one after that is going to be linezolid. And this antibiotic also works from a different mechanism. It actually binds to the 50S ribosomal subunit. And this one often is going to, at least at our hospital, need an infectious disease consult to come with it to help with administering it.
Okay, so now let's talk about gram-negative coverage.
So now for our gram-negative. So now we have these bacteria that have also a cell wall, but this lipid bilayer as well. And penicillin, certain ones that have these beta-lactam rings, they also are going to be effective against gram-negatives. It's just certain ones of them that are going to be more effective. And the classic ones that we go to for this one are going to be our ampicillin and amoxicillin. These ones can fight against gram-negatives, but if we want to make them even more effective, one thing we can do is add in a beta-lactamase inhibitor. And so beta-lactamase is an enzyme that bacteria are going to produce that are going to pretty much cut up that beta-lactam ring in our antibiotic that we're giving. And so they're making our antibiotic non-functional. That bacteria is fighting back. And so we can then fight back again against that by giving a beta-lactamase inhibitor along with our beta-lactam antibiotic, and that can make it even more effective against those bacteria that have developed this beta-lactamase. When we add a beta-lactamase with either ampicillin or amoxicillin, we get two antibiotics that are classically used. The IV version is Unicin, and then the PO version is Augmentin. And so these ones are very commonly used, particularly used with infections in the mouth, because they fight a lot of bacteria that we're going to see there. Now, if we want to move up the ladder a little bit with that, another one that we can use is called Zosyn. And this one also functions similarly, but the benefit of Zosyn is it also covers a gram-negative bacteria called Pseudomonas. And this one we can be particularly worried about in the hospital setting. And so the benefit of Zosyn, kind of above the Unicin Augmentin, is that extra coverage of Pseudomonas. Now, if we want to move up the ladder again in terms of coverage, then we get to the carbapenems. And so these ones are going to cover some gram-negative, also some gram-positive, like the other ones we talked about, some anaerobes, as well as Pseudomonas, except for one of them, ertapenem, does not cover Pseudomonas. Most of the carbapenems do.
Okay, so where do cephalosporins fall in this diagram that we're describing?
Okay, so cephalosporins, this is a group of antibiotics that spans coverage from gram-positive to gram-negative. And the way that this group of antibiotics is kind of organized is by generation. And so we have 1 really through 5 in terms of generation. And each generation has different properties to it in terms of what it covers. When we start out with the first generation cephalosporins, these ones are going to be covering mostly gram-positive organisms. The classic ones for this one are going to be our Ancef or cefazolin, and then Keflex or cephalexin. And these are going to be ones where we'll reach to all the time for soft tissue infections, for surgical prophylaxis. Then, as we move down the generation, so second generation, third generation, we're moving towards more gram-negative coverage. One way I like to think of this is if you have a grandparents, parents, kids, they get kind of smaller as you go down. And so as you go down these generations, you potentially have antibiotics that can cross through that bilayer, affect the cell wall and are able to affect more of those gram-negative bacteria. The third generation, cephalosporin, that includes ceftriaxone. That one we'll see, particularly on gen surge rotations. And then the fourth generation is cefepime. And the unique one with that is that cefepime does cover Pseudomonas. For us in plastic surgery, I think the ones we'll see the most are going to be our Ancef and Keflex. That's first generation, again, covering a lot of our gram-positives.
All right. So tell me about coverage of GI bugs.
GI bugs, one thing we're going to have to worry about with GI bugs, particularly, is going to be the anaerobes. So anaerobes also can be gram-positive, gram-negative, but often when we talk about coverage for anaerobes, we talk about them separately. Two of the main antibiotics that we turn to when we're worried about anaerobic coverage are going to be clindamycin. Clindamycin is an antibiotic that works by binding to the 5-DS ribosomal subunit. And then also Flagyl, which is metronidazole. Flagyl is going to inhibit nucleic acid synthesis. Kind of the classic way people talk about it is if you want to cover anaerobes anywhere sort of above the diaphragm, so in the mouth, what you'll reach for is clindamycin. And if you want to cover anaerobes sort of under the diaphragm, those GI bugs, either in the GI system or vaginally, you're going to reach for Flagyl.
What other antibiotics are important for us to know about?
Two other antibiotic classes that are going to be important to know about are particularly ones that cover MRSA, those particular soft tissue infections that we'll come across a number of times that are oral antibiotics. So ones that we can send patients home on, but we know are going to cover MRSA. And one class of that is going to be Bactrim. And so Bactrim functions by inhibiting folate formation, and this one is going to cover MRSA. Our other classic one that's an oral antibiotic, also comes in IV though, is tetracycline with doxycycline. Doxycycline is also going to cover MRSA. This one works by inhibiting the 30S ribosomal subunit.
Okay, now that we have learned a little bit about antibiotic coverage, let's talk about soft tissue infections. Erica, what can you tell me about this?
All right, so when we have a patient come in with a soft tissue infection, think about as gram-positive. So these bacteria that have the prominent cell walls. And going against this bacteria class when you're picking an antibiotic. So the first classic thing we'll see is cellulitis. And so for cellulitis, we'll see redness of the skin. And the initial thing you can think of is there's going to be a lot of potential strep or staph that we'll see for that. Now, if we have patients with cellulitis, or we're really not as worried about MRSA, one of the go-tos that we can do if we want to do IV is going to be our Ancef or cefazolin. Remember, that's the first generation cephalosporin. Or if we want to do oral, we can do our Keflex or cephalexin. Generally, we'll give these for about 5 days. Now, an alternative to either of those is clindamycin, and that can be both IV or PO. Clindamycin does cover MRSA. This is a classic alternative that it's recommended at the hospitals we are. Now, if you're worried about MRSA with a cellulitis patient and you want to go with an IV antibiotic, you can start off actually just going right to vancomycin. So vancomycin is an IV antibiotic that we can use that will cover for MRSA. Generally with this one, it's going to come along with a pharmacy consult because of the toxicities of vancomycin. Now, if you want to go right for a PO antibiotic and you're worried about MRSA, we can give our Keflex, that classic first generation cephalosporin, but also add on, for example, doxycycline. And so we know that we're going to be covering for MRSA with that doxycycline in addition to having Keflex, and give that for 5 days.
What other considerations do we need to know specifically regarding toxicity?
Ancef and Keflex, so those first generation cephalosporins, they are cleared renally. And so we do want to adjust for renal function. Generally, the way we would do this is spread out the dosing based on low creatinine clearance. For those patients, you want to take a look at how their kidney function is doing, what is their creatinine clearance, and then take a look at a reference and see what the recommendations are for that patient's creatinine clearance and how you would space out the dosing dosing of that to be safe for that patient. Generally, for all cephalosporins, we're going to need to do this, really except for ceftriaxone. That was our third generation cephalosporin. This one actually is significantly excreted in bile and it does not need to have renal adjustment, where all the other ones, for the most part, will. Our other one there, if we're worried about MRSA, is vancomycin. And vancomycin at our hospitals does automatically come with a pharmacy consult, and that is because it is toxic to the kidneys. And so we want to be very careful about dosing vancomycin and making sure that our levels of vancomycin that are in a patient are not too high and causing too much kidney injury. This one little thing they say is trough too high, kidneys will die. Trough too low, infection will grow. So we want to have a perfect in between when we're giving this drug. The other toxicity for vancomycin to keep in mind, both for your patients and for questions that come up, is ototoxicity. So if you have a patient on vancomycin who starts talking about ringing in their ears, you want to think, okay, could this actually be from vancomycin if they're on it? The other one that we talked about here with the PO version for covering for MRSA was doxycycline, adding that in. And doxycycline, there's a couple things to think about. The way I like to think about it is doxycycline, so cyclin for cycle of life. Doxycycline is going to impact birth control. For patients who, say, are young females and maybe using oral birth control pills, you want to let them know that they should use additional contraception while they are taking this to reduce the risk of pregnancy. And then in patients who are already pregnant, you do not want to use doxycycline because there are two things that doxycycline can do. It will stain teeth, and then it also can suppress bone growth. So you want to avoid it in pregnant patients, and then also be careful with young females because it can reduce the effectiveness of birth control. Now, some other things. Doxycycline can have pretty severe pill gastritis. So when patients take it, you want to recommend that they sit up for at least 30 minutes after they take doxycycline to avoid that side effect that can happen. You also want to tell them to avoid taking it around the same time that they're taking calcium food or supplements to help promote the actual absorption of doxycycline. And then lastly, doxycycline, you think of the circle of a sun. So doxycycline is going to make people more sensitive to the sun and much more likely to get sunburned if they're out in the sun. So they definitely want to use sunscreen or avoid the sun while they're on it. Now, with all of those things to keep in mind with doxycycline, we actually don't have to adjust for renal function or any hepatic function. So you at least have that positive of it.
That's great. That really makes me want to start singing The Circle of Life. That was very helpful to remember that, so I'm never going to forget doxycycline. Okay, so now let's talk about soft tissue infection in the critically ill patient.
Yeah, so one of the infections that we are always worried about when a patient comes in is whether we could be looking at someone who has necrotizing fasciitis. Some other ones are Fournier's gangrene or gas gangrene, really those infections that are going to require us to go right to the OR and do pretty substantial washouts to try to get control of this infection. These patients, they're going to come in, they're going to be critically ill, have hypotension, they may need pressors, and they're going to have these infectious clinical symptoms as well. And so in addition to taking these patients to the OR for a washout, there are recommended antibiotics to use. For necrotizing fasciitis, for example, there's a couple antibiotics that are recommended as a baseline to start patients on. First one of those is vancomycin. So vancomycin, is going to help with covering our gram-positive and our MRSA. Then in addition to that, the recommendation is Zosyn or Piptazo, going to extend our coverage out to more gram-negatives, to Pseudomonas, to anaerobes, and then also clindamycin. All three of those, vancomycin, Zosyn, and clindamycin, are the ones we want to add on for patients who are coming in where we're worried that what we are looking at is necrotizing fasciitis, in addition to going to the OR for washout.
Okay, so what are some things we specifically need to consider for using antibiotics in these patients?
There has been some studies that have come out recently looking at the combined use of vancomycin and Zosyn. And both of these are antibiotics that can impact kidney function. These studies have looked at the likelihood of patients getting acute kidney injury when these antibiotics are used in combination and have found that there is an increased risk of kidney injury in these patients with that combined vancomycin use. There's been a call to action to try to actually avoid using those two together and to use something instead of Zosyn, say using vancomycin. So cefepime is that fourth generation cephalosporin. It's also going to hit those gram negatives. It does also cover for Pseudomonas. So instead of vancomycin, you could go for vancomycin, or you could do, say, vancomycin. And so that one's going to hit the gram negatives. It's going to hit Pseudomonas and anaerobes. And so you'll have similar coverage, but less of the acute kidney injury risk that we're seeing with combined vancomycin.
Great. So let's move on to the patient with an abscess. What do we need to know?
All right. So you have a patient coming now who actually has an abscess that's developed. And the main thing we want to do with a patient who has an abscess is actually do an IND and drainage. The thing we want to think about with abscess, though, is staph. The way I think about this is staph is a gram positive that grows in clusters, where strep, for example, was pairs and chains. I think of a cellulitis, it's common with that, and we have a chain sort of running down the skin, where staph, it's growing in clusters and it's clustering up into an abscess. For staph, the main worry with staph, of course, is that we have methicillin-resistant Staph aureus. So we want to consider using medications that are going to be effective against this. So some of our basic penicillins are out when we talk about this. First line, we're going to do the incision and drainage. But if we want to have an IV antibiotic added on with that, the first go-to generally is going to be vancomycin, also generally along with our pharmacy consult to help with that risk of kidney injury that comes with that. Or if we want to have a PO antibiotic that we can give by mouth, we can do the incision and drainage with doxycycline. Doxycycline, we can do PO. It also does come IV, so it is an option that you can do for that. Now remember the cycle of life and all the things we had to keep in mind with doxycycline, but it doesn't need to be renally adjusted, so it is an option for those patients where that is a consideration. And then the other one, if we can't use doxycycline, we can also consider doing PO Bactrim, because that will cover our MRSA. And generally, we're going to give those for about 5 days if we want to give antibiotics in addition to the incision and drainage. For Bactrim, so Bactrim also does need to be renally and hepatic adjusted. The new one here is the hepatic adjustment. Just take a look at how their liver function is and resources to see how you would adjust based on that. And then the main thing with Bactrim is there is sulfa in it. So you want to take a look at the patient's allergies and make sure they don't have an allergy to sulfa medications before you administer Bactrim.
All right. Let's now talk about prevention of soft tissue infection, specifically for either trauma or surgery.
For plastic surgery, we're going to get a lot of calls to come in and evaluate, large lacerations or wounds that patients have that need to be cleaned up and sewed back together. So there always is a question of, should you give antibiotics now? And generally, it's recommended to give prophylactic antibiotics if you have a wound that you're looking at that's really grossly contaminated or cannot be adequately cleaned right away, just to help give that extra backup. The main thing that you want to do, though, is clean that wound well when you're going to sew it up. Now, if you do have a large soft tissue trauma where you do want to give antibiotics, the go-to for that one is generally going to be Ancef or your cefazolin, that first generation cephalosporin. You can give 2 grams IV, either for 1 dose or really no more than 3 days. The alternative to that could be clindamycin. That one you can also give IV, 1 dose in addition to cleaning it up and closing it. Surgery also is kind of a similar scenario, though much cleaner. The classic thing we'll give for a lot of the surgeries that we'll do that are just dealing with soft tissue and the skin is going to be 2 grams of Ancef IV right before beginning surgery.
Okay, Erica, what do I need to know about microbes that have come from the mouth or from oral flora?
We have many more microbes to consider. I was reading somewhere that in a clean mouth, there can be up to 100,000 bacteria living on each tooth. And in a not clean mouth, that can be up to over 1 billion. A lot of microbes living in our mouths. In the Go-to antibiotics for the mouth are going to be Unicin and Augmentin. And so if we go back, these are going to be ones that either are ampicillin or amoxicillin with a beta-lactamase added on. And they hit gram-positive, gram-negative, and then also some anaerobes. The alternative to either Unicin or Augmentin, for example, our hospital was low on Unicin for a while. The alternative to that generally is going to be clindamycin, and that's because it's hitting some of those anaerobes that we'll see in the mouth.
Are there any adjustments that need to be made due to renal or hepatic impairment?
We do want to take a look at renal and hepatic function. So there are renal adjustments that need to be made for both of those. And then for the hepatic adjustments, the recommendation is to monitor hepatic function, particularly if you're going to be using this for a while or if the patient already has hepatic impairment.
All right, how should we treat patients after facial fractures? Should we be treating them with antibiotics to prevent infection?
Question always is, do we need to treat them prophylactically? The greatest benefit that's been seen is actually for mandible fractures that are going to need open reduction. So generally these are going to be open mandible fractures where the bone then is exposed to that bacteria. And the go-to for this is going to be Unicin, 3 grams IV. You can give it every 6 hours, but prophylactically you really don't need to give it more than 24 hours. So just give it for one day, an initial backup, in addition to then going ahead and fixing that mandibular fracture. The alternative to this is clindamycin, 900 milligrams IV. Again, less than a day that you need to give it. It's just an initial backup.
Okay, we commonly see patients with animal bites, especially dog bites to the face in kids. Happens basically every time I'm on call. It's really sad to see, and very, very frequently these kids get infections. What organisms are expected from these bites?
So when we're talking about animal bites, so this is going to be dogs and cats that we'll see most frequently. The way I like to think of it is that dogs and cats like to roam in pastures. And Pasteurella is the bacteria that we're seeing most in these infections. The other thing that we actually can see some are human bites. And so this can actually be a human bite that happens during an altercation, but also what we call a fight bite. So when someone is in a fight and punches someone in the mouth, and that person's tooth, for example, can injure the patient's hand, that hand can then get inoculated with bacteria. And the way I think of that one is like, oh my gosh, eek, you just got bit by a human. And Eichinella is the bacteria that we classically see for this one. Both of these, Pasteurella and Eichinella, are gram-negative facultative anaerobes. And so we want to look at our anaerobic coverage when we're thinking about covering for these bacteria.
Should we be treating them with antibiotics prophylactically?
We want to think about the scenario that we're in terms of treating them. Of course, we're going to wash them out, potentially loosely close them up. We want to then take a look at, who is this patient and where is this bite? Antibiotics are recommended if the patient is immunocompromised. So we want to give them that extra backup, be able to fight this. If they do not have a spleen, is another situation. If they have advanced liver disease, if they already have edema of the affected area, and then any moderate to severe injury, particularly those to the hand or face. So classic ones for us to get called about from plastic surgery, and then any injuries that penetrate the periosteum or joint capsule. And our go-to for this, again, going to be Unicin if we want it to be IV, or Augmentin for PO, and then the alternative for those is going to be clindamycin.
What about patients who show up after bites and they are currently infected? What do we do in that scenario?
So that scenario is going to be a similar type of antibiotics that we're looking at, just a longer amount that we're going to give it. IV option, we have our Unicin, but we'll generally be giving that for about 5 days. If that patient has purulence of the area, we're going to be more worried about maybe Staph aureus being in there, and so adding on some extra coverage for Staph aureus. So in addition to Unicin, that's going to cover gram-negatives, those anaerobes, the Pasteurella or Eichinella that we're worried about, we may add on, say, doxycycline, because that one's going to cover our MRSA in addition to that. Or if we want to do PO, it'll be our Augmentin, and then PO doxycycline, because doxycycline comes PO or IV. Now, with all of that, that's taking into consideration all the things we have to think about with doxycycline and with unison and augmentin in terms of looking at renal function or hepatic function or what's their age, are they pregnant? A lot of things you have to take into account for these antibiotics.
All right, moving on to patients we have operated on. What should we know about post-op fevers?
Other area that us as plastic surgeons may need to be administering antibiotics is going to be our post-op patients that start developing a fever. And so what are we worried about when we have a patient who is post-op and has a fever? The thing we go to kind of to remember this is the W's. And so the W's here: wind, water, wound, walking, wonder, the classic ones that are taught. So first is wind.
Okay, this is pneumonia, right? What should we know about this?
So atelectasis could be one. We just have some collapse of them, but pneumonia is the main one we're worried about. And so in that fever workup, we'll get a chest x-ray, and you want to take a look and see if there's any consolidation on that chest x-ray. Patients also, if they have pneumonia, they're going to have a productive cough. They may have some dyspnea or tachypnea, sputum production, and they'll have that fever that we're trying to do a workup for. And if it's severe and you're concerned about it, you could obtain a sputum to take a look at what those bugs really are. The treatment for this, if it's pneumonia in general, is going to be more community acquired, is going to be our second generation cephalosporin. We haven't really talked about that much. That's cefuroxime. And then for hospital acquired, which is going to be more probably in the realm of patients we have, we're going to do vancomycin and cefepime. So covering for MRSA, and then cefepime really is going to hit a lot of the other bugs that we could be looking at.
All right, so moving on to the next W, water. Water as in urine, infected urine, or UTI. What should we know about this?
In that fever workup, in addition to a chest x-ray, we classically are going to get a urinalysis and urine culture to see, okay, could it be their urine that's infected? And generally, even if someone has signs of infection in their urine, we generally don't treat them unless they have symptoms. So signs and symptoms of UTI, that's going to be pain with urination or burning with urination, suprapubic discomfort. And then in that urinalysis, two of the things you really are going to look for is the leukoesterase and the nitrates, in addition to having pyuria or having a white blood cell in there. So leukoesterase, nitrates, white blood cell. In the urine culture, you want to see over 100,000 CFUs per mil. And if you have all of those along with those symptoms, you're going to move towards treating them with antibiotics. Now, one difference here is if you have a patient who's pregnant, you generally are going to treat them whether or not they have the symptoms if you do see those same things in their urinalysis or urine culture. Now, for treating them, there's a couple options for treating UTIs. It seems to be kind of doctor's choice in terms of what to pick. The common PO one, for example, is nitrofurantoin. And then another one that's an option for IV or IM is ceftriaxone. There's other things you can add if there's other bugs that you want to cover. And then for patients who have been in the hospital for a long time, you want to cover for more things, particularly Pseudomonas, because the one recommended here is Zosyn.
All right, moving on to the next W, wound. So that's easy for us. We see these all the time, post-operative wound infections. What should we know about this?
Gram-positive is going to be what we're worried about the most. So that can be hit by our penicillins, our Ancef, our Keflex for our cephalosporins, or if we're worried about MRSA, we're going to reach more towards for IV, vancomycin, maybe linezolid if we want a stronger antibiotic for that. Or if we want to keep it as an oral antibiotic, we have our doxycycline, our Bactrim, and our clindamycin.
All right, next is walking, or maybe we should actually say not walking, because walking refers to a patient with a DVT, so possibly from immobility after surgery. And also, wonder. Can you tell me what is that about?
So wonder could be drugs that they're on, any new medications that they've been put on, or other things that we need to consider. So we have our classic things, the wind, which from our lungs, the water, UTI, wound from the surgical site, walking or the DVTs, and then wonder is sort of that next category of other things to consider.
Okay, Erica, that was a ton of information. The only thing that I would add to that great overview is that sometimes in plastic surgery, we do use leech therapy. And what you need to know with leeches is that they can harbor the organism Aeromonas hydrophila in their gut. And you need to treat this prophylactically with a fluoroquinolone, which is ciprofloxacin. And if it is a child, you must avoid fluoroquinolones, and therefore you need to use a third generation cephalosporin. Erica, can you give us a really quick rewind?
Talked about a lot of different things here. We have our gram-positive bacteria. These bacteria, remember, have the cell walls. So a lot of our antibiotics are going to be fighting against those cell walls. The kind of initial antibiotic for this was our penicillins, which still can be used in some situations, but we have a lot of resistance to those now. So we're going to be bumping up the chain. Our go-to for gram-positive often are going to be our cephalosporins, which are Ancef and Keflex. And then if we're worried about MRSA, we're going to have our vancomycin for IV, and then options for sometimes IV or PO. We have our clindamycin, our Bactrim, and our doxycycline. For gram negatives, we're commonly going to go to Unison or Augmentin. And then if we want to also cover Pseudomonas, we're going to be looking at more Zosyn and our carbapenems. Also, later generation cephalosporins are going to cover more of those gram negatives. Now, if we want to do anaerobes, some of those antibiotics we talked about cover anaerobes, but the classic ones that are reached for if we're above the diaphragm is going to be clindamycin, or if we're under the diaphragm, it's going to be our Flagyl, our metronidazole.
Okay, everyone, I know that was a ton of information, and the visual content to this is actually super useful. So if you haven't already, check out this episode on our YouTube channel. It's titled The Loupe Podcast, and Erica has created some very helpful diagrams for us to use. And we will also post some links to some additional helpful YouTube videos in our show notes. Also, thank you, Erica, so much for giving all those really helpful tips on how to remember this, such as circle of life. In addition to these diagrams, I think I know antibiotics and mechanism of action way better than I used to. So if you haven't already, as I said before, make sure and check that out. Thanks, Erica, for doing this today and helping us with the overview of what a plastic surgeon needs to know for antibiotic use.
Thanks so much for having me.
To our listeners, thank you for your support. If you like this podcast, make sure and spread the word. Tell everyone. You can see us on Facebook, YouTube. We also have an Instagram account. We are posting very frequently pop quizzes, which are basically like flashcards, so they can be very helpful to supplement this episode and our content. So make sure and check us out there at the Loupe Podcast to get in the loop.